Good morning. I'm delighted to be here this morning on 2 hours of sleep. I've been going from one coast to the other, and the reliability of the airline industry does not have a code of ethics anymore, I don't believe. So with that, and I actually want to preface something that Dr. Main said. I sit here on the shoulders of 14 other people. So when I do this presentation, I represent an interprofessional professionalism collaborative. I don't do this alone and could not have achieved what this group has achieved to date without all of them. So once we get to the names of the groups, I'm going to introduce a few of my colleagues who are here, who have been longtime collaborators in this initiative and who also all believe passionately in where we're going. I also want to thank Dr. Hafferty because he set me up really nicely. I appreciate that. And some of the questions you raised about possibilities, can you have interprofessional definitions and still maintain individual professionalism? The answer is absolutely yes. So I think there's some things here that will resonate with some of your comments, and I'm glad I didn't get the one about governance and having to resolve that because I wouldn't want to take that one on either. So the burgeoning of an idea. Once upon a time, an idea was shared with other health professions organizations that had some interesting possibilities for further exploration and uncharted waters. For the idea to germinate, it required the ability of these multiple health professions to cobble together their different perspectives in order to create a new vision with new possibilities. So in the beginning, to begin our journey, the topic of professionalism was examined by reviewing several documents from individual health professions, including their respective code of ethics, core values, their literature, professionalism-specific assessments for students, and other relevant documents such as pharmacy that happens to have an oath for professionalism. The comparison yielded several interesting findings, the most prominent of which was that all the professions examined had a code of ethics, articulated core values, had literature about professionalism, and all were exploring a way to measure the concept of professionalism in their students and practitioners. However, at that time, there was a paucity of resources addressing the concept of professionalism beyond a single profession. So following this initial review, the question arose, would a shared discussion about professionalism and core values among health professions be in fact worthwhile? At the time, APTA had actually set aside about $65,000 to have a consensus conference to bring these groups together, and I said, can we just bypass the $65,000 and bring them together to have the discussion without all of that, if they would be willing to be involved? And in fact, they said, if you can do it, go for it. So the way that organizational process began in 2006, CEOs of 7 national health professions organizations, and they may have been education or combined practice, and 1 assessment organization, the National Board of Medical Examiners, were contacted to see if this topic was something that would be worthwhile exploring as a shared discussion that could transcend health professions. Each of the organizations, after being given some background information, said, yeah, we'd like to try that. They sent an expert to represent the health profession who knew about professionalism, and agreed to sponsor them in an exploratory process. However, the first year, this group never convened face-to-face. We only did it by phone. We had no money. So we began the concept of professionalism, exploring the concept of professionalism without having a compass or a roadmap or financial resources. It was a discussion in process. In our early phone conversations, we discovered there are many parallel and overlapping efforts with each of our professions to address issues associated with professionalism, such as how do you define it? How do you teach it so you know you really have achieved the outcome? And how, in fact, do you measure it? Conversation began to take some shape, direction, and a purpose, beginning with defining what a shared professionalism framework might look like across health professions. As we continued our conversations, we identified some other key health professions that needed to be part of our conversation. And similar to the first organizing group, we called those CEOs and said, would you be willing to suggest somebody to join the group? And if in fact we meet, you'll be responsible for their travel and we'll take on the rest. So we continued the exploration, and during that exploration, an interesting process happened in the group. We had first a session called the mea culpas. So each one of us identified where we had gone poorly in our relationships with other health professions. So nursing and medicine sort of had a whatever, and then PT acknowledged whatever, and each one of us sort of did what I call the confessional. And we identified where we had stepped on everybody else's toes and where our relationships were probably in a political arena, in practice, in payment, not good. And we also said, can we set that aside to talk about this topic that really isn't about that? It's about something larger and something bigger for all of us. And then what happened is there started to become some interesting trust and respect and honest learning about what is it you do, why do you use that, why do you use those terms, what does that look like for each of you. And by 2009, you'll see that we were actually called the Ad Hoc Group on Interprofessional Professionalism Measurement, and we said that won't fit anywhere, I can't write it anywhere. We all said we need a new name, and that was one of the first collaborative decisions that we came to, the Interprofessional Professionalism Collaborative. That's what we're talking about, or the IPC. At that point in time, there were 11 organizations that represented 10 health professions and 1 assessment organization. Today, we now have 13 organizations that represent 13 health professions and 1 assessment organization. And the list up here are all the organizations that are there, and you'll see that some are educationally oriented and some are combined, where they have the education and the practice depending on them. I need to acknowledge 3 of my distinguished colleagues who are part of the IPC who are here with me today. Dr. Loretta Nunes, and I don't know if she's in here or in the overflow room, but she's from ASHA, and she represents both audiology and speech-language pathology. She is dual certified. Dr. Catherine Gruss from APA, who represents psychology, and she's right over there. And Dr. Catherine McGinn, who represents nursing from the American Association of Colleges of Nursing. And you'll notice on this group, it's an interesting group of professions. So it ranges from medicine, and internal medicine joined the group later, and there's a reason why they joined, because they were working on some things on professionalism and had heard about what we were doing. But it has psychology, veterinary medicine, dentistry, physical therapy, occupational therapy, and it covers a wide gamut of professions, which actually has been fodder for some very interesting conversations along the way as well. So with that, I want to go back to some terminology, and Dr. Ballard had talked about that as well as Dr. Hafferty. But professionalism is sort of often defined with disciplinary silos. So the word professionalism is intended, or concept of interprofessional professionalism is supposed to bring professionalism and interprofessional healthcare together. Those are the 2 constructs that come together. And it bridges professional practice or professionalism and interprofessional healthcare. But sometimes it's often defined by disciplinary silos, as we found in most of our publications. Likewise, professionalism can be misused to justify unchallenged professional autonomy or inhibit collaboration across professional boundaries. In fact, consider the number of boundaries that have been established by the health professions under the guise of professional autonomy. Another widely used term, often interchangeably, is interprofessionalism and interprofessional healthcare. These terms are used to describe the delivery of healthcare by members of different health professions in a collaborative manner. So you saw the definition, but what's interesting is this definition took the IPC nearly 2 years to come to an agreement about what is interprofessional professionalism. The choice of words and how you use words and those meanings to all 13 health professions had to mean the same thing when we use the terms. That's not an easy task. So the terms all reflected common meaning and purpose to all of us. Part of the definition was derived from the work of David Stern, reflecting those common values to all health professions, and the concept of multiple health professions working collaboratively, or the team-based care, with an outcome of optimal health and wellness in individuals and communities. Consider the definition of interprofessional education and the importance of learning from, with, and among other health professionals. Then consider the principles of what we have in this definition, which is really about working together, aspiring to, and wisely applying these principles, with the goal is around patient care, optimal health and wellness in individuals and communities. You'll learn a little bit why these terms were selected and how those terms have framed where we're going in this process. So a little bit about the construct. The construct of interprofessional professionalism uniquely overlaps the concepts of both professionalism and interprofessional healthcare. This construct reflects a transcendent transcendent phenomenon that applies across profession to support coordination and communication and care for the benefit of patients, clients, family caregivers, and their communities. Interprofessional professionalism builds upon research of team functioning, interprofessional education, interprofessional care, and relational coordination. Now we're going to take a look at our purpose of the IPC and our vision and how we're trying to bring these concepts of professionalism relevant across the health professions. So you'll see the goal, we have three. And that took us a while. We sort of meandered until we got to what the goals are. So the first was to define a clear definition of interprofessional professionalism, where we get to put a little check next to that one. The second is to develop an interprofessional professionalism assessment, or IPA, focused on health professions' entry into practice. And somebody had mentioned the way you really do this is you have to be able to assess or measure behaviors if you're really going to have this construct. That's where we're headed. And then hopefully, if the assessment we're developing is determined to be psychometrically sound, we will go on and develop the resources for how to teach people how to use the resources and what's involved. Part of our literature in the assessment was we looked at a number of assessments that are out there, and they do exist for teamwork, they exist for communication scales, they exist for a number, but they do not exist for interprofessional professionalism. We could not find anything. So what's our vision? Where are we going? Someone said, is the vision related to just professionalism or is it related to patient care? And you're going to see here it's related to both. So it says interprofessional professionalism, when practiced by all professions, will improve healthcare quality and outcomes for patients and clients, and I would add their families and caregivers, promote a culture that values and fosters individual competence, and enhances both education and practice environments. We believe that this vision is intended to bridge both academic and practice. It's not siloed in either environment, and it needs to be modeled and promoted in both environments. It provides a unique emphasis that underscores communication, collaboration, and negotiation across professional boundaries. The vision highlights professionalism as a resource for promoting skills, values, and organizational structures that facilitate interprofessional care. And likewise, the competence concept is distinct in focusing on competencies, values, and norms that multiple professions have identified as critical to promote effective interactions in the provision of care. The next slide is sort of an illustration, and it should look familiar because it certainly builds on the recommendations of IOM. So we talk about, you have the big circle, that's professionalism, and that certainly reflects a larger venue, everything that could fit in there, my identity, my professional image, specific. Interprofessional professionalism is a subset of that. We believe that if you add the next equation, collaborative teams with effective communication who are behaving in ways that reflect interprofessional professionalism. In fact, we believe the connection will actually augment patient outcomes for quality care, safety, and in fact, greater patients' family and centered care. If professionals, when they get in a room to interact with each other and the patients at the center of that team behave in ways that really reflect the concept of interprofessional professionalism, it will change the culture of our practice. We will in fact look different. And you're going to see some examples of what does that terminology really look like that would tell you that. Now in this case, professionalism is not an end in itself, but it supports the ultimate goals of patient-family centered care, quality, and patient safety. While broader discussions of professionalism frequently endorse these outcomes, they seldom emphasize cooperation among members of multiple health professions as a mechanism to achieve them. In the context of increasing complexity of care, narrower definitions of professionalism may actually undermine quality and safety by distracting clinicians from the need to collaborate effectively across professions. So many of you should be scratching your head and saying, okay, I need something concrete to hold on to so I understand what this IPP stuff is. We all needed that in our group. We said, okay, give us a hint of what are these behaviors. I'm going to give you examples that are actually coming off of our pilot tool that we're about ready to launch, and then I'll take you backwards how we got there. But I think sometimes getting the ending so you can fit it in may help in terms of thinking. So I'm going to give you 6 categories that we have and give you an example of each of what an IPP behavior would look like in practice, not in education. It could be, but it's practice oriented. So the first is communicates with members of other health professions in a way they can understand without using profession-specific jargon. If in fact we're going to be able to do this, we all need to talk the same language. One of the first things we learned as the group was forming is we had all kinds of jargon and nobody understood anybody, and we're all in the healthcare business. That was one of the first concerns. So here's another one. Demonstrates confidence without arrogance while working with members of the health professions. You can fill in whoever you want, but arrogance and competence and interprofessional competence doesn't go together because people are not approachable. Altruism and caring, all of us have this in our core values, places patient needs above own needs and those of other health professionals. The patient is still centric, it's still core. Now, you begin to see that one profession could not have written these particular behaviors. It does require a group of professions. The next ones are even probably more poignant. Contributes to decisions about patient care regardless of hierarchy or profession-based boundaries. I'm not sure that we have that currently today. How about ethics? Reports or addresses unprofessional and unethical behaviors with working with members of other health professions, not only your own, but if you were to observe something that in the end did not serve the patient's interest, you're responsible to report that as part of the team. And the last one, accept consequences for his or her actions without redirecting blame to members of other health professions or the team for that matter. Now, you can clearly see an interprofessional organization to these. None of them are specific to any one profession, and they're all oriented around a team concept. Do you get a sense now of what these behaviors would look like? One of the things we're aware of is we can obviously say we may or may not, to some degree, show some of these, but we may or may not in all practice settings be doing all these right now. But if we were to do that, that is what the culture would look like. So those are just a sample of what we have in the instrument, which is actually 26 observable behaviors. Let me take you backwards a little bit to understand how do we get to this point so you can decide, are these really quality, observable, single-barreled, measurable behaviors? That's what we're looking at and where we're going. So we did our initial literature review in 06. In 07, we started this amazing iterative process, and we identified over 200 behaviors related to interprofessional care and professionalism. And what happened was we had 38 themes or categories. We just had this huge mess, basically. And we had a wiki page, and the thing was all just one giant color. And we had categories like advocacy, beneficence, competence, moral courage, patient outcomes, respect, and they went on and on. We then winnowed those 200 behaviors down to 65 across 8 categories that eventually were altruism, accountability, caring, ethics, excellence, care delivery, communication, and respect. One of the ways we reduce them is anything we wrote in the negative that says, we don't want to see this, we don't want to see that, that's probably not a good way to start off an instrument with everything you don't want to see. It really should be in the positive. So a number of those dropped off. And then anything that was single profession oriented, not around a team concept, we said that's individual professionalism, that's not interprofessional, we dropped those. So the second iterative process that we worked on took 65 behaviors down to 43, eliminating those that weren't central. And then you'll see, we then took those 43 behaviors and we all went to each of our health professions, a town hall per se, and there were 3 to 4 of us on the IPC representing these presentations. There was the host, whoever the profession was, but 3 other ones. We all got to have a peek into each other's health professions, and I have to tell you that was one of the most fascinating processes to hear their conversation vis-a-vis your profession and what some of the issues were, and they were very different, and that was a wonderful process. But we got everybody involved in helping us to understand, are these behaviors worthwhile? Are they measurable? Do you think we're onto something? Are we getting in the right direction? We then, after those presentations, had a wiki page and asked people to fill out a survey to help us with some information to turn out if we had a problem or not. So then we conducted an online survey, and you'll see the real question of the survey was asking, are we on the right track? Are we on the right track? And the question was, if we're on the right track, is this something that you all could measure in your own professions and others, et cetera? Then we, in 210, had experts review our instrument and give us feedback, and actually some of them are in the room here today. We then went on with internal medicine and National Board of Medical Examiners, actually did 2 rounds of cognitive interviews with typical preceptors who would use this to ask the question, is it clear? Could you use it? Do you understand it? We're now at the point where we actually have approval from the University of Mississippi IRB with Dr. John Bentley, who's our consultant biostatistician, but he also happens to be a pharmacist, who is helping us with this process. And we are about ready to, with more than 50 institutions and their health professions, with the students who are in their final internship, to actually go out and test the tool. The lessons we've learned about how do you set up a multi-institution, multi-site, multi-clinic IRB is huge. So that's been the most difficult part, is the methodology. We can't wait to get data. If you want any of the works, there are 2 articles that the IPC has published in the Journal of Interprofessional Care and the Journal of Allied Health. We also have a website, and you can track us and see where we're going and ongoing with definitions. So finally, in conclusion, here's our 3 future initiatives and where we're going. We're now moving in the next year for empirical support for an assessment instrument on interprofessional professionalism. If those turn out to be psychometrically sound, we'll disseminate the findings, and that tool will be made widely available for people to use without a fee, to begin to bring it into the community. And then finally, to create a resource toolkit to help people with this concept and how to apply it in their education and practice. Thank you very much.
Jody, thank you so much for a wild ride over almost a decade's worth of work. Very, very important. And there will be plenty of opportunity for questions to ask her some more information before this hour concludes. But now I'll invite Eric to come forward, Chief Medical Officer and Senior Vice President at the ABIM, to share a bit more about some of the efforts in interprofessional